Sachin sir, I think you can
No,
probably, yeah, we are live. You can start.
you're live. Here it is not seen.
Yeah, we are live. No, no, we are live. We are live. You can start the session.
Okay, okay, fine. Hello,
Yeah.
friends. This is Dr. Sachin Dalal. I'm very happy to introduce Dr. Jay Mehta and Dr. Shilpa GB. Jay, everybody knows, does everything right from ultrasound to advanced laparoscopy to fetoscopies and a master teacher, master trainer. Joining us is celebrity gynecologist from Bangalore, Dr. Shilpa GB, probably one of the youngest Foxy Society presidents. And I have seen her growth in the past 2 months. She has grown from 5,000 odd followers on Insta to 104, 105,000 followers on Insta and 104,000 followers on Insta. And that is absolute hard work. एकजुट dedication के साथ में she has reached that, and the way she is going, I'm sure she will be touching the 1 million milestones. So this series is on the lines of the super duper hit series done by Dr. Shilpa GB and Dr. Jay Mehta on Fertility Masterclass, followed up by Dr. Aarti Dina Dayal, who did the series of Blast series. And now, getting feedback from a lot of colleagues, we are starting this new series where we will be taking interesting case discussions and detailing out what was the case, what is the diagnosis, what is the treatment, and do our best to provide scientific data and evidence-based medicine to our colleagues. We are planning to hold around 100 to 150 such cases, maybe 2 to 3 cases a week. And this is going to be available on YouTube for future referencing if anybody wants to do so. So, Jay, should I start with the case?
Yes, please, sir. Please start.
Perfect. So, as we are talking about the first case, this is a young couple, 28-year-old. Both are 28. Her AMH is 3.4, thyroid, prolactin, all other blood reports are normal. Husband's semen report is normal.
Okay.
Viral markers are normal. This girl is giving history of 2 abortions.
Okay.
First was 22 weeks.
Simultaneously, I'll, sir, simultaneously start writing what you said
Yeah,
on the whiteboard.
yeah,
Okay.
yeah,
So you said that the girl is 28, the boy is 28. All
correct.
right. And then you mentioned that her AMH is normal. Her
Right,
AMH is 3.3 something you mentioned. TSH
right,
and prolactin is normal you mentioned.
correct,
And you mentioned that the husband's semen analysis is normal, right?
correct. Absolutely normal.
Okay, fine, fine.
Okay. Now, this girl
Yeah,
is giving history of 2 abortions in the past.
right,
First was at 22 weeks, the baby had multiple congenital anomalies.
right.
That time, the NT scan was normal, dual marker test was done, that was normal.
Okay,
So, labor was induced and the pregnancy was terminated.
okay,
However, the baby was not sent for autopsy then. This was the first pregnancy.
okay. First
Okay.
pregnancy was, as you mentioned, 22 weeks, and it was multiple anomalies, right? You just
Yes.
mentioned that.
Multiple
Okay,
anomalies,
fine.
NT scan and dual marker test was normal.
Acha, NT was NT scan and dual marker test was normal,
Normal.
but there was no fetal autopsy which was done.
No, no, no. No fetal autopsy was done.
Okay, okay,
Yeah.
fine.
So after a year of this, she became pregnant again.
Right,
And this time, uh,
right.
the USG showed a thick nuchal translucency of 4
Okay,
millimeters.
okay,
And her dual marker came very strongly positive for Down syndrome.
okay.
The risk was 1:10.
Oh, okay,
So NIPT was done, and NIPT also came strongly positive.
okay,
She was not willing for amniocentesis and fish. She was counseled, but she
okay,
was not willing, and
okay.
pregnancy was terminated.
Oh, okay, okay.
Okay, so this is
Yeah,
2 abortions. So
This is
after
two
that,
abortions.
yeah, so after that, karyotype was done for the couple. That was absolutely normal.
All right.
Entire APLA profile, anticardiolipin antibodies, protein C, protein S, everything
Yeah,
was done.
yeah.
Everything was normal.
Everything was normal. Okay.
Yes. And now the couple has been recommended for donor LIT.
Oh, acha. Okay. So second pregnancy, if I can just write down, NT was elevated, as you said, Downs was positive, correct?
Perfect.
Downs positive. And now after all this, all the RPL markers are normal. And
Yes.
now she has been recommended for donor LIT.
Yes, yes, yes.
Oh, okay.
So in
So
this case,
I think,
Jay, in
hmm,
this case, before you
yeah,
start off,
yeah,
just one query, which a lot
yeah,
of people do, and we see in clinical practice.
yeah,
Looking
yeah.
at this, do you feel, or Dr. Shilpa, do you feel that torch titer should have been done for this patient? Would have been help?
Not at all. Not at
Okay, okay,
Not at
fine.
all. Not at
Yeah,
all.
okay,
Yeah, I
fine.
mean, okay. So, sir, the history from all the things which you have presented in the history, okay, so far, every parameter, every damn thing which is normal for this girl. One thing or two things which are very important which come to my mind and I think which people should know. See, when the first pregnancy was a pregnancy with multiple congenital anomalies, you mentioned NT scan was normal,
Yes.
right, in that pregnancy, and this is a young couple. So I just want to ask one question. I'm sure you know, probably it has not been specified. Is it a consanguineous marriage between the couple? Is it
No, it
something like that between the couple?
no, it's not a consanguineous marriage.
It's not a consanguineous marriage. Okay. Has after two abortions, have you sent the couple for any form of genetic counseling to form the genetic diagram for the family or something like that, or it has not yet happened?
Not yet happened. That is not yet happened.
Not yet happened. Okay. Two or three are things are very important. See, if the first pregnancy is with multiple congenital anomalies, one thing is there that it can just be a, by fluke that the patient has developed multiple congenital anomalies. It may or may not be a chromosomal problem. That is one thing which we have to keep in mind. I think you also mentioned that the karyotyping of the couple is normal, right?
That,
So the couple is 46XX, 46XY, but we must remember that this is the karyotyping of the couple, which probably would have happened based on the standard method of doing the karyotyping. All right. So this is broadly going to look at the mega structure of the chromosomes. It is going to look at translocations. It is predominantly going to look at deletions. It is going to predominantly look at numerical problems or anatomical problems as far as the genes are concerned, right? And if there is something like that, it would have probably pointed out like a balanced translocation, inversion, you know, something like that would have been pointed out. So I think that is also completely ruled out, right? She's not even very old. She's 28, 29.
28,
So,
28.
there is no maternal age syndrome as far as this is concerned. What is typical and what I find something little abnormal to recommend donor LIT in this situation is the history in which two abortions have occurred.
Hmm.
See, I'll just, if I can just share the screen
Yeah.
again, I'll just share the whiteboard. I request people to not scratch on the whiteboard again and again. There's no point. Yeah. Um, so yeah, I'm again sharing the whiteboard. And so, you know, whenever we are trying to recommend donor LIT, or basically whenever we are trying to recommend LIT to anybody, LIT is basically going to be, our lymphocyte immunization therapy. All right. So first thing which people should remember about LIT is that if I can change the color here, yeah, I can go to red. It is a completely experimental therapy. In fact, I was speaking to somebody in Germany because these days, a lot of these Indian patients who have failed three, four IVF cycles, and once their insurance in Germany is finished for IVF, they are sent to India for IVF. So I was speaking to somebody in Germany, and even my uncle, who is a bone marrow specialist, he tells me the same thing that in most of these countries, when you try to talk of something like lymphocyte immunization therapy, which we in India do, I mean, at least we do it with a lot of caution, but you have very small scale isolated setups also across the country who are attempting to do these types of things. this is a case which is actually handled by the transplant department in most of the countries. Okay, so we have to keep in mind that it is a very serious therapy. It can have some consequences if there are any form of complications. And at the moment, as far as fertility is concerned, it is an experimental therapy. It may give maximum 10 to 12% benefit, and that too in cases where CDC cross match of the couple is negative. Okay. And that practically means that if I just look at the husband here and the wife here, all right. So, what is basically a fetus? A fetus is a combination of the husband and a wife. So, it is something called as a semi allogenic graft. That is our fetus, right? It is a semi-allogenic graft. 50% is from outside. Matlab 50% country comes from the husband, so it is semi-allogenic. Correct? So whenever you have a semi-allogenic graft which is inserted inside the body, basically in pregnancy there is no immunosuppression. It is something called as immunomodulation which occurs in pregnancy. And if the immunomodulation is successful, it allows this semi-allogenic graft to flourish and grow, and which is why majority of the women became pregnant, and majority of the pregnancy continues for so many women, and all these types of things. What we should understand in this entire situation, okay, in this completely entire situation from this history, is that when the pregnancy is growing, there is something called as a blocking antibody. Okay, this blocking antibody is something which develops in the mother. And once this blocking antibody is developed in the mother, it is this blocking antibody which allows to protect this fetus. So when you do LIT, practically what do you do in LIT? You take the husband, who is that semi-allogenic graft person. You take around 90 ml of his blood. Sometimes you can take 70. The husband has to be fasting for approximately 4 hours. Rarely in our country we see people who give bowel preparation for LIT. All those things are simply not required, right? But the husband has to be fasting for approximately 4 hours. That is predominantly in order to ensure that the cholesterol content of the blood goes down. Understanding? And the turbidity of the blood goes down. When the turbidity of the blood goes down, the lymphocytes which you extract can be extracted easily. It is a simple Ficol solution with a tube which is available. I have not done the process personally, but in my hospital, on an average, we will do 3 to 4 procedures like this every month. Very strongly indicated. We don't normally recommend a procedure like this to all the people because it costs around 2 lakh rupees to do. So it's a very serious procedure otherwise, and it can have only 10% benefit. So these lymphocytes which are taken from the husband are then prepared on a slide, and the pathologist will examine the slide to rule out any form of lymphocyte errors, defects, and all these things. And then an aliquot of around 1 ml is made, which is injected into the wife's fora. So it is believed that these lymphocytes will produce a blocking antibody in the wife. It will create a similar reaction like having a fetus, and the next time the wife becomes pregnant, she has blocking antibodies, so her pregnancy can continue. But this is predominantly for early pregnancies, 6 weeks, 8 weeks, 9 weeks, and embryonic pregnancies, biochemical pregnancies, and all these types of things. This is probably got nothing to do with the case currently mentioned, because one very important rule of doing LIT, when you do LIT, and if you are doing, let's say, IVF, the embryo has to be a euploid embryo. That is the most important thing. Okay, one thing Dr. Dalal mentioned, that the second embryo was already a Down syndrome, so that means it was an aneuploid embryo, and in the first fetus there was multiple anomalies, and not fetal autopsy has not been done. So basically, we don't know the genetic condition of that fetus. Maybe even that is an aneuploid embryo. So the immediate counter question to this is going to be, but Dr. Sachin Dalal just mentioned that the karyotyping of the couple is normal. So please remember, in such type of history at this moment, from what Dr. Sachin has told me, the only thing which I am going to do for the couple is something called as whole gene exome sequencing. Okay, whole gene exome sequencing is a simple blood test. It costs around 35,000 rupees per individual to do. Husband and wife both are supposed to do it, and because there is no history of consanguinity, okay, it becomes an even more important test, because this is going to identify point mutations basically which are going to occur through the entire DNA of that individual. And when you try to identify these point mutations which are going to occur, you may get certain additional information. Okay. So then the obvious next question is going to be, there are just two situations in this. Again, I'll try to draw. Uh, Sachin sir, just see if you can see my screen. I hope you can.
Yeah, I think.
You can see the screen. You can see the
Yeah.
ureter also, which we drew. Yeah. So, right. So what's going to happen is that when you do whole gene exome sequencing for the couple, basically there are just going to be two scenarios, right? Either there is going to be a defect, okay, and this defect is going to further require something called as genetic counseling. And after genetic counseling, majority of the couples are going to end up with ICSI with NICS or PGTA, PGTM, or they are going to opt for third party reproduction,
What is
right?
NICS?
NICS is non-invasive chromosomal studies, okay, which is done on the embryonic fluid, which we do very, very routinely, almost 25 to 35 couples in a month, and it is very, very effective. Okay. The other answer to the whole gene exome sequencing is going to be that it is going to turn out to be virtually normal with no major problems. And remember, in that situation, okay, you basically have to allow the couple to try conception naturally. You don't really have to get bothered as to what is going to happen. Just allow them to try a conception naturally. Coming to the question here, where Sachin sir has specifically asked a question which raises a big question mark about using donor LIT for this history. Okay, so remember, when you say donor LIT, you are basically trying to say that you are going to use a third party blood, okay, not the husband's blood. Normally LIT is using husband's blood. Here you want to use third party's blood and inject that lymphocytes inside the wife's hand and probably ensure that the blocking antibodies are formed. But remember one thing, this has got no meaning. Okay, see, remember, Dr. Dalal just mentioned in his first line that we are going to be pretty frank and we are going to try and answer questions which have some logic, right? We do know that in our country there are a lot of practices which may be practiced which have got no scientific basis to it. Okay, and donor LIT is practically one of those practices. Okay, which has practically got no meaning in a situation in the case in which it has been mentioned. All right. Also, simultaneously, it is very, very important for us to understand and for us to counsel this patient that despite such type of a history, okay, despite such type of a history, as sir has mentioned, majority of the parameters for this girl are absolutely normal. Despite such type of a history, couples would end up conceiving naturally. Couples don't really end up requiring IVF. Couples don't really end up requiring a vast majority of uh, you know adjuvants in a situation like this, because both the occasions the pregnancy has crossed 13 weeks of gestation. In both the occasions there was no pregnancy induced complication. In both the occasions there is nothing which is suggestive of an early pregnancy loss. Okay, so there is no such thing. There is no preterm labor which has happened. The labor has been induced. There is no cervical incompetence, so you don't need to put a laparoscopic cerclage. So if you mathematically work out, everything is fine. I just want to state one more thing. Normally, in this situation the couple will insist and our brain will also tell, and under peer pressure, we will also end up doing something called as genetic counseling to the couple. We will send the couple to a genetic counselor or a fetal medicine specialist. Some fetal medicine specialists are trained in genetic counseling, like how Raghav does at our hospital. So what typically happens is, what they do is they mark the entire family tree, and then they try to mark the gene tree, okay, for that particular couple. And when the whole gene exome sequencing is usually fine, the answer is like an MRI report. Kindly correlate clinically. Understanding? So basically, even the genetic counselor is not going to give a concrete evidence or a concrete answer to this. Their answer is going to be हो भी सकता है, try भी कर सकते हो, नहीं भी हो सकता है, डॉक्टर ने बोला वो follow करो, something like that. Okay, so we have to be very careful in that situation. And if in case some of us do have the time, you should attend 3 or 4 genetic counseling sessions which the genetic counselor is doing to understand what they are counseling. Okay, and when you listen to the counseling the fifth time, you will only start counseling on your own because it is not very difficult. Okay, And I think that is the take home point, because when we look at this case and when we study this case so far, no indication. In fact, no indication of LIT only. Forget donor LIT. No indication of LIT. No indication of donor LIT. No indication to do anything further. Uh, no indication to, even if a 3D pelvis has not been done, definitely do it just to rule out any anatomical defects in the uterus. But otherwise, whole gene exome sequencing, it will take around 24, 25 days for the report to come in. And if the report is viable and report is good, then allow the couple to conceive naturally. It is going to be nice in their next pregnancy. There is no indication of doing chorion villus sampling for this pregnancy at 9 weeks. Better option is to do NIPT straight away, okay, at approximately 10 to 11 weeks, and wait for the NIPT report and then take it from there.
So, summarizing, there is absolutely no role of donor LIT. For a second, when I read donor LIT on paper, I actually thought that they are going to do a donor IVF and they are going to do a LIT for that couple.
So if you do a donor IVF, then there is absolutely no indication to do LIT.
Absolutely.
Yeah, so in our country we have many cooked up indications. एक abortion हो गया, LIT करवा लो. I mean, all that is not justifiable, right? Like how you
Absolutely.
typically say, RPL profile is going to cost 20,000 rupees, but the treatment is 4 rupees ka EcoSprint. So rather than spending that 20,000 rupees for the couple, you might as well give EcoSprint to everybody, and you will see what happens, right? So something like that.
And do we need to do HLA typing prior to LIT, Jay?
Uh, yes and no. It depends. See, HLA typing is something which you have to understand. If there is too much of HLA matching between the couples, no, it is not very good. Okay, it
Okay.
can increase the risk of abortions in that couple, especially HLA allele C. HLA has allele A, allele B, allele C, and multiple such type of sub alleles. Especially in allele C, if there is matching and the cross matching is more than 55%, that means more than 55% of the alleles are shared, then it is believed, okay, that the recurrent abortions are going to be slightly more, but there is no treatment to that. You can't really change somebody's HLA typing. It is a marker which is expressed on the lymphocyte unless you do a bone marrow transplant. And that is not really recommended in IVF or in fertility or in pregnancy, right? So I personally again don't think, I personally don't think it has a very great role. CDC cross matching to rule out blocking antibodies is good. Okay, you may do CDC titers based on certain situational aspects. Okay, but apart from that, I personally don't think we should do all these things. Especially in this case, because the pregnancy has been established and crossed first trimester. If everything was 4 weeks, 6 weeks, and all these things, then we may more look towards chronic endometritis. We may more look towards, early pregnancy loss factors, which could be highly related to Mullerian anomalies or 3D anatomy of the uterus or something like that. But for an established pregnancy like this, I don't think it is indicated at all.
We should
Yes, Shilpa
actually
ma'am.
we should add sperm DNA fragmentation in such cases. Sometimes we
Yeah,
see, the fragmentation, though the parameters may be slightly abnormal, but the DNA fragmentation index is very high.
yeah,
So type of patients who will end up like this. So today also I saw a similar patient. Of course, like she had 2 abortions similar with congenital anomalies, and then one live baby. Then after that, 2 IUDs, 1 molar pregnancy. So she has actually 1 living child and 5 abortions. So she had come
right.
for similar this thing, like she already had LIT 2 times before, and I was just discussing it with Dr. Jay when he had called about this class. So I think as both of you are strongly suggesting that LIT should not be offered in such cases, especially when there is congenital anomalies, and the genetic testing is the main way of investigation or main line of investigation in such cases. So exome gene sequencing is again, whole gene exome sequencing is again, which is not very popular because they do karyotyping, which is just a numerical thing, and they just stop it there. especially when they find this POC karyotyping, if they do, and if it says like, it is of not very significant finding, some heterozygous, some gene they will write, and then they will say that it doesn't have any significance. It can be a normal variant. So that is when everything will start getting very confusing and very cloudy. So doing all those things, I don't know how far it is going to be helpful, but whole gene exome sequencing is something which we all should make sure that we do before offering LIT, before offering other forms of fancy treatment which are available in the market now.
Yeah.
I
So
just want to clear one misconception before we two misconceptions actually. Madam, you mentioned about high DNA fragmentation. Actually, if the DNA fragmentation report is done on computer assisted platforms and not on cytometry, it never picks up the DNA as strongly as it picks up on a CASA platform. Understanding? On CASA platforms, if the sperms are apoptotic in DNA, more than 35% or more than 40%, then the risk of congenital anomalies, despite everything else being normal, is very high, as
yeah,
you mentioned, right? So, apart from fragmented sperms, we should look at degraded or apoptotic heads in the sperm, and that is something which is very important. And second, I think you were trying, no, I also forgot, it just slipped out from my head. You were trying to mention something.
Clinically insignificant reports in the genetic testing, you mean? Did you want
No,
to?
it just slipped off when I started speaking about the DNA fragmentation. It's okay.
I'll just
Jessica,
add
you
a
were saying something.
couple of points. Yes. So
Yeah.
a lot of people might not be aware about whole genome exome sequencing. So
Yeah.
just for them, I mean, when we were doing residency, we used to do genetic abnormality testing by just doing a standard chromosomal analysis, which is to give whether 23XX is there, 23XY is there, or some translocation is there. Now, with the technology coming in, they are able to give us more than 5,000 genes, and they are able to
Correct.
identify a single gene disorder in the baby. Like
Yeah.
right now, I am having a couple non-consanguineous. The child had a strange abnormality. Genetic abnormality was not detected on routine chromosomal analysis. And they just
Right.
thought that probably it is obstetric cause. Then when they came to me for a second opinion and for a second child, I told them to get a whole genome exome sequencing done. And at that point of time, a very rare gene defect was found. And to be, I mean, it was astonishing that the father and the mother, father is from Bombay, mother is from Aurangabad, non-consanguineous. And sadly, both are having the same gene defect,
Oh,
right? It's a very rare gene. So don't waste patients' money on getting a regular karyotyping done. Rather than that, get a whole genome exome sequencing done. That is one. And just summarizing this case, LIT is
Sachin sir,
only
sorry,
an,
I actually
yeah,
remember. I actually
yeah,
remembered what had lost in my
yeah,
mind. Yeah.
yeah.
See, all immunological therapies, any form of immunological therapy, it can be tacrolimus, it can be intralipid, IV immunoglobulin, LIT, thymosin, whatever you want to do, it is only for euploid embryos. If
Absolutely.
you have an aneuploid embryo, nature will abort it no matter what you put.
What?
No matter what you do, nature will abort it. You can't supersede nature in that. It is only and only for euploid embryos.
And a euploid embryo is not a grade 4 AA embryo, you know. I mean, it looks fine and good IC mass and all that. It has to be undergone a PGTA to detect whether it is euploid or not.
Absolutely.
Right. And LIT has only to be done, that is in the last resort for patients who has had recurrent implantation failure or recurrent
Despite euploid
pregnancy
embryos.
loss despite euploid embryos in the first trimester, not in the second trimester. And this is a classical case where both the babies had a conj anomaly, and that is the reason why they were terminated. So this is absolutely not an indication for donor LIT.
Right. Thank you. Thank you, guys.
Thank,
Thank you, Sachin sir,
thank
for
you so much.
discussing your case with us. Thank you, Shilpa madam.
Thank you, sir.
Celebrity. Thank you, Shilpa madam, for joining us.